I'm Dr. Jeremy Rochelle. I'm one of the lecturers in public health here at Victoria University. We have a very special guest with us today, Professor Gavin Turrell from the Healthy Livable Cities Lab at RMIT. He's the inaugural and still the current lead investigator of the Habitat study. Welcome, Gavin.
Thanks, Jeremy. It's good to be here.
Okay, we might start off with an overview of the Habitat study. First, what does Habitat stand for?
Habitat stands for How Areas in Brisbane Influence Health and Activity. It's an acronym for the project, which was we can easily recall the project with a term like Habitat. So it was a very useful title, if you like, for the project.
So you started back in 2007 was the baseline wave.
Correct.
And how many waves have you had so far?
5 waves so far. First wave, as you said, was collected in 2007, and then after that it was in 2009, 11, 13, and then 2016. So roughly 2 to 3 years between the waves for 5 waves.
Okay, so you were planning the grant. So the first wave was back in 2007.
Yes.
When did you start thinking about putting the grant together?
Probably 2006. A large project like Habitat requires a lot of lead-up work in terms of thinking about the focus of the survey, thinking about the focus of the study, what's it going to involve. And so there's a lot of work that gets done behind the scenes before you actually implement and administer the study. So I would say about 2006, and then we went out into the field for the first time in 2007, around May, June. And we go out each year that we collect data in May, June, because one of the focuses of the study is physical activity, and we need to make sure that we collect data at approximately the same time each year to take account of what are called seasonal effects.
And what was your inspiration for the study? Do you have an epiphany, or did you read something in the literature that inspired you?
I've always been interested in how place influences health and well-being, how place shapes us as people. Obviously, our health and well-being is influenced by individual level factors, our biology, our genetics, our behaviours. But I've always been interested in how where we live influences our well-being and our health, both mental and physical. And so prior to Habitat, I'd conducted a number of other large multi-level type studies which had investigated place and health. And there was a gap in the literature where at that point in time in 2007, we didn't really know a lot about how the neighbourhood environment influenced physical activity. And so I thought this would be a very useful topic to investigate. We've known for a long time that individual level factors like people's age, their gender, their attitudes, their motivation levels, and other things influence their physical activity. But we really didn't have a good understanding of how people's neighbourhood environment influenced whether or not they engaged in physical activity, and then the flow-on effects of that to health and well-being. So there was a gap in the field, and I wanted to undertake a study that could address those gaps.
I want to talk about the team that you formed for the baseline wave. And I think this is relevant for anyone who's planning a project, but even for early career researchers that are forming a supervisory team and thinking about the types of expertise that they might need as part of that team. So do you want to talk about who was in that team in the baseline wave and what their expertise were?
Sure. You're correct. Forming a team for a large project grant is crucial. The team needs to be made up of experts in different areas. So you need balance among your team members. In the Habitat study, we had experts in physical activity, we had experts in the built environment, we had professional statisticians, we had people with strong sort of understanding of survey design, epidemiology, public health. So forming forming a project team needs to have people who can speak to the various aspects of the project, because you don't want to have a team of people. You don't want to set up a project where you have gaps in your team. You want to be able to do the best project possible, and for that to happen, you need people with expertise covering all parts of your project. It's I guess analogous to a football team. A football team needs specialists who perform certain roles and functions, and therefore it forms a team. You can't have a team of all forwards, for example. It doesn't really make a team. So the same applies with putting together a project. Similarly with supervision. If you're a postgraduate or a student looking for PhD supervisors, ideally you want to choose a supervisor or seek supervisors out who are specialists in their field, who are regularly publishing, because they then are going to also be a means by which you will get published as a PhD student. So choosing your PhD supervisor wisely is very important in terms of your own future career and prospects as a researcher, particularly if research is something that you would like to do into the future. Choosing your supervisor, making sure that your interests align with them, and that the supervisor will be able to appropriately mentor you professionally and I guess personally as well, because the supervisory relationship is just that. It's a relationship that you form with somebody over 3 to 4 years, and that relationship needs to work at many levels. So that at the end of the PhD process, you come out of it as a fully rounded researcher with a number of skill sets that you've developed and some outputs that are going to, like publications or conference presentations, that are going to set you up for a future in research, if that's what you want.
I want to get down into the nitty-gritty of the methods now. The sampling approach at the baseline wave of Habitat, how did you go about that?
As mentioned at the outset, Habitat was designed to look at the relationship between the neighbourhood environment and people's health and well-being. So the sampling involved selecting neighbourhoods in Brisbane, 200 of them, and individuals living within those neighbourhoods. We used an approach called a stratified, multi-staged random sample. And essentially that involved categorising all of the neighbourhoods in Brisbane, and the ABS back then, at least in 2007, had a statistical area unit called a census collectors district. And there are approximately 1,600 of those in Brisbane in 2007. And each of those districts has what's called a socioeconomic score. And so we ranked all of the 1,600 collectors district by their socioeconomic score. So it formed a distribution from the poorest neighbourhood in Brisbane to the richest neighbourhood. And then we divided that distribution into what are called deciles. That's a statistical grouping of 10%. So we divided those 1,600 neighbourhoods into groups of 10%. It's called a strata. And then from within each of those stratum, we sampled. So there's 10 strata, and we sampled 20 neighbourhoods from each of the 10 strata. We sampled them at random to give us 200 neighbourhoods. Once we'd selected the neighbourhoods, we then went and selected individuals at random, aged between 40 and 65, from those neighbourhoods. And I probably should just emphasise that we selected people aged 40 to 65 in 2007 because while the focus of Habitat was on the neighbourhood environment and health and well-being of individuals, the other primary focus of the study was healthy ageing. We were interested in how where you lived influenced your health and well-being as you aged. We all don't age at the same rate, and we know from decades of literature now that our ageing is influenced by our social and economic environment. And we wanted to understand whether that also extended to your neighbourhood environment. How does living in a certain type of neighbourhood support your health and well-being as you age, for example? So sampling occurred among people aged 40 to 65 in 2007, 200 neighbourhoods, and it was 11,065 people that we sampled from those 200 neighbourhoods. So it was about 85 people on average was sampled from the 200 neighbourhoods.
So tell us about some of the data you collected. So there were two sort of components, I guess, a part of Habitat. The first one was a survey, and the second one was the linked geospatial data. So tell us about some of the data collected in the survey.
The neighbourhood level data that we collected related to the built and social characteristics of the areas where people lived. So, for example, the residential density of their neighbourhoods, the street connectivity within the neighbourhoods, that is the street networks, the layout of the streets, the green space that were in people's neighbourhoods. Crime, we also looked at crime in neighbourhoods. We looked at people's perceptions of their neighbourhoods as well. So we didn't only collect built environment data about neighbourhoods, we also collected people's perceptions of their neighbourhood. We collected people's attitudes to things like whether the neighbourhood was cohesive, whether they could trust their neighbours, whether they felt comfortable walking in their neighbourhood at night and during the day. So the data collected was a mix of both area level characteristics that described the places where people lived, but also we collected individual data about how people perceive their neighbourhood environment. Of course, we also collected a lot of other type of data in terms of measuring physical activity, measuring people's attitudes to physical activity, people's attitudes to transport, because we collected quite a bit of data on the objective features of transport within neighbourhood, bus routes and things like that. So Habitat has a very rich source of data about the neighbourhood environment in a whole range of dimensions to do with the built, the social, the transport environment, crime, as well as a very large database on people's attitudes and values and socio-demographic characteristics. And they're clearly important factors that influence your health and well-being. So things like their age, their gender, their income, their education level, their occupation. And all of these things were collected at every wave in the same way, in an identical way, because Habitat is a longitudinal study. And so we wanted to make sure that we were collecting things in the same way at each time point so we could examine things like change.
I found it interesting that you've collected data on similar variables, similar things in different ways. So you did ask people about their perceptions of crime in the neighbourhood, but then you also had Queensland Police reported crime. And I'm cheating here. I've got a list in front of me. You've got the streetlights from Energex, the energy provider in Queensland. You've got weather data from the Bureau of Meteorology, green space, hilliness, bikeways, parks, traffic hierarchy, public transport, the bike hire scheme. Was it a challenge getting all of that data from a variety of sources?
Yes, it was. One of the things that Habitat, I think, was very successful at doing, and it did take a lot of time and resources, was to obtain data from multiple different government agencies and organisations to build a very unique database. So it involved a lot of networking, a lot of contacting organisations to secure the data like streetlights, for example, so the local electricity supplier in Queensland, we contacted them, spoke with the relevant person in their organisation, and were able to obtain a database of every single streetlight in Brisbane in 2007 and each of the year after that. So yes, there is a lot of work in obtaining built environment data. One of the key partners with the Habitat study was Brisbane City Council. And Brisbane City Council were strong supporters of the project, and they provided us with a lot of very useful data that was crucial or fundamental to the success of the Habitat project. For example, Brisbane City Council provided us with what is called a cadastre. And a cadastre is basically the street network for the whole of Brisbane. And the Habitat study was conducted in what's called the Brisbane City Local Government Area. It's one of the largest local government areas in Australia, and it has a very complex street network. And Brisbane City Council were great partners in that they provided us with the cadastre that allowed us to identify and characterise the street network in terms of what was on the streets. Were the streets highly connected or not? What transport routes were along the streets? And also create estimates of congestion and things like that. So the cadastre also allowed us to calculate measures of residential density. So in some neighbourhoods of Brisbane, people live very close proximity to each other and very close proximity to things like train stations or bus stations or shops. Whereas others out on the outskirts of the city typically don't have those sort of resources close by, so those neighbourhoods are less dense. And we know from previous research, if we live in a more dense neighbourhood, that you walk more because things are closer. So we wanted to capture as best as possible the built environment features of neighbourhoods that were going to help us understand the complexities of the factors operating at both the individual and the neighbourhood level that influenced various forms of physical activity: walking, cycling, swimming, all sorts of different types of physical activity. And so we also separated between walking for transport, cycling for transport, walking for recreation, cycling for recreation. So we looked at many different aspects of activity and also issues that were related to activity, like people's mental and physical health and well-being. So we want to make sure that as best we could, we covered all of those factors that were likely to advance our understanding and knowledge of physical activity, the consequences of high levels of physical activity or being inactive, and how the built environment or the social environment of neighbourhoods influence that.
So I can see that working with one city council that provides that data, being the Brisbane City Council, made your job a lot easier. So to do Habitat in Melbourne, the equivalent would be there are about 34 local governments in Melbourne that you would be required to work with as opposed to just the one in Brisbane, which I guess improved the feasibility of the study going ahead.
It did, you're right. Working with one council is in many respects simpler. You have to deal only with one bureaucracy. There still are challenges, of course. There's still a lot of work in terms of securing relationships with organisations so that there's trust and reciprocity between them, and that we were able, over a period of time, to reach a situation where Brisbane City Council were able to support with confidence the Habitat project. If you were trying to do Habitat in Melbourne, you're right, there's 30-odd city councils. And so to negotiate with each separate council, as we did with the single council in Brisbane, would have been immensely challenging. Possibly one of the downsides, though, with working within one city council is that you don't have any policy variation. The one council applies its policy pretty well uniformly, one would hope, across the whole Brisbane City Council jurisdiction. And so really you then can't compare the impact of policy on people's behaviour or their health and well-being. Whereas in Melbourne, if theoretically we were able to conduct the Habitat study in Melbourne and sample people from all of the 34 councils and were able to get objective data from each of the councils, then you would have policy variation. You'd have differences between city council jurisdictions in terms of how they built and designed their neighbourhoods. And that would provide very useful information for comparative purposes to see what policies were working for the people and what weren't, and what things could be improved. We weren't really able to do that in the Habitat study in Brisbane because it was one council implementing one policy for the whole of the city.
I want to talk about the response rates and potentially the biases that arose through the response rate. So how many people received an offer or an invitation to be in the study, and what do you know about the people that didn't respond?
Response rates for a study like Habitat are crucial. The goal is to get as high a response rate as possible to the survey. That is, get as many people as you can to return the survey that when you send it to them. High response rates mean better quality data and less bias in the data. And it's particularly important for a longitudinal study like Habitat to make sure that you get as high a response rate as possible at each wave, but particularly at the baseline wave. So with Habitat, we ended up with 11,035 people at baseline, which was a response rate of approximately 68%. So that's quite high for a study of its kind. And we were very pleased with that, but it took a lot of work in terms of the design of the survey, a very complex and detailed recruitment strategy for contacting people, following them up with those people, sending them reminder letters. There's quite a well-detailed and well-evidenced collection method that we followed, and we wanted to make sure that we did everything possible to increase the response rate. The trouble with a low response rate to a survey is that your data often is then biased. And by that, I mean the statistical data that is produced from the study doesn't really closely reflect the population from where it's drawn. So the ideal for a study like Habitat is to sample and to collect data from enough people so that their responses and any statistical analysis you do with those people looks very similar to what would be happening in the population. Because from a statistical point of view, we're more interested in the population than we are with the sample. The sample is just a slice of the population because we can't afford to obviously sample the whole population. So we sampled a small subset of it, and that needs to be as representative of the general population or the population to which you want to make inferences as possible. And I think with Habitat, we were able to show by comparing the data within the study to the national ABS census data that Habitat was a representative study of the population aged 40 to 65 in 2007. However, I should also make the point that certain groups were underrepresented in that. And lower socioeconomic groups and people from more disadvantaged areas were less likely to return the survey. And this is well known across many studies of the world, going back many years now. So certain groups tend to be less likely to respond to a survey. And so there is always some element of bias in your data that's collected. It's unavoidable. But the challenge is to minimize that bias and then to be able to investigate your data, to quantify it, to know how big and in what ways the bias might influence your results. And of course, if you have bias in your data, that's going to have implications then for what you can say in terms of policy, because ultimately Habitat was about trying to improve the common good. It's a public health study that is fundamentally about improving the lives of neighbourhoods and the people who live in those neighbourhoods. And typically that's done through policy and by local councils and state governments and federal government. They all are, in one way or another, making decisions and developing policy that shape the lives of people in neighbourhoods. And so with Habitat, we were wanting to generate evidence that was going to hopefully inform those policy-making decisions so that it would improve the neighbourhoods that people were living in, and therefore, especially as they were ageing, and therefore also to improve their health and well-being.
In 2007, the first wave of Habitat, that was what the initial grant was proposed for, just for one wave. And then it was decided to move Habitat to a longitudinal study. So I just want to ask, what were some of the benefits, or what was the rationale for moving to a longitudinal study?
The Habitat study in 2007 was initially called a cross-sectional study. That is, we initially set out to look at people at one point in time. Cross-sectional data are very useful, and they've provided a lot of important evidence for policy. However, soon after we started to develop the Habitat study, we thought, why not extend this from a cross-sectional study to what's called a longitudinal study, which is where you follow the same people over time. Right. So with Habitat, we decided that we would like to try and set up initially a 3-wave study, so that we would collect data in 2007, 2009 and 2011. And there are many benefits of that, because a longitudinal study allows you to examine change in the environment and change in how people age over time, and then the relationship between the two. So if our environment changes over time, does that have an influence on changes in our health and well-being? It's quite a powerful policy statement to be able to say that if we can intervene in an area and change it for the better, whatever that might look like, and that brings about an improvement in people's health and well-being, that's quite powerful. If you've only collected data from one time point, while it's useful, it's not particularly strong from a policy purpose or what's called a causal inference perspective. That is, we'd like to think that if we changed the neighbourhood environment, it would change the way that people behaved and therefore improve their health over time. And the only way, and that's quite powerful data, if you can demonstrate that interventions that change neighbourhoods also change people, that's very powerful. And that's why we set Habitat up as a longitudinal study soon after it was initially funded as a cross-sectional study. Because there are many benefits, obviously, of doing that. And now we've been able to extend Habitat by a number of additional waves. So we were successful in getting funded to extend initially by 3 waves. And then we got 2 more rounds of funding to extend the project through to 2016. And we're actually undertaking another data collection wave this year in 2022. So that's quite exciting, because it's been quite a few years now since we've been out to the field. 2016 was the last time we collected data from the Habitat participants. But this year, 2022, we've been fortunate enough to have funding provided via a colleague and another organisation that will support another data collection wave.
I want to talk about some of the issues that arise, or challenges that arise, from transitioning to a longitudinal study. You mentioned that you started in 2007. Most recently, it was 2016 was the most recent data collection. There's another one happening now. But in 2011, the Australian Bureau of Statistics, they changed from the Australian Standard Geographical Classification to the Australian Statistical Geography Standard. Tell us how that affected Habitat and the geospatial measures you were collecting.
Sure. One of the goals of a longitudinal study is that you measure something in the same way at every time point, be that whether you're measuring the environment or whether you're measuring individuals. You want to be able to measure the same thing in the same way at every time point, because that's the way you can best model change. If your goalposts or your measures are constantly changing across the various data collection waves, it makes it difficult, if not impossible, to reliably model and examine change. And so what happened in 2011 was, as Jeremy mentioned, the Australian Bureau of Statistics introduced a new way of defining a neighbourhood or an area. After Habitat had already collected data from an older previous way of doing this, the ABS introduced a new way halfway through the study. And so that presented all sorts of challenges because the area unit that we were using for Habitat prior to 2011 was potentially now going to be different after 2011. And that would have really made it challenging, if not impossible, to be able to look at how neighbourhoods changed over time and how that influenced health and well-being. So what we decided to do, we decided to stick with the original area unit that had been used by the ABS prior to 2011, called a Census Collectors District, and we're able to use what's called geographic information systems to maintain the same area unit after 2011. So we had staff on the project who had specialist skills in geographic information systems, or GIS, and they were able to maintain the same geographic unit across the full range of the study, even though the ABS had changed the geographic classification. We were able to adapt and therefore have a common area unit across the duration of the study, which is a very strong aspect of the project. I should mention that Habitat's probably one of the largest longitudinal multi-level. And by multi-level, I mean that we're looking and measuring things at different levels. We measure environments and we measure people. So they're different levels of measurement. We could have potentially focused on families, households, as well as individuals. That would have been another level. We didn't with Habitat. We focused on the neighbourhood environment and individuals who lived in that environment. So yes, the change in the geography was a challenge. I think we adapted well to that challenge, and Habitat has benefited by that because it's been able to use the same area unit throughout the duration of the study.
So in 2007, 9 and 11, you just had the surveys and the geospatial data. But then you built on that for 2013 and 16. What did you add into the Habitat study?
We introduced what was called a clinical sub-study, and up until for 2007, 9 and 11, we had undertaken what's called an observational study. And that means we relied on people's reporting of their health and well-being and their perceptions of the neighbourhood. In addition, of course, to objectively measured built environment data, at the individual level, we relied on people's reporting. Now, there's obviously problems often with the way people report answers to surveys. They're not always accurate, or recall might be, people forget or they exaggerate. And so the quality of the data that you can get from self-reports is often questioned, and rightly so. I think one of the hallmarks of science is critique and questioning. And so it is the case with observational reporting of data. But having said that, observational data is still useful. But what we decided to do to somehow build on and take a different perspective of things with people's behaviour was to look at measuring their health and well-being directly. So we undertook a study that was called a clinical sub-study, which was a sub-sample of the original Habitat participants, and we focused on measuring their physical function. And for approximately 700 of the Habitat participants, from 2013 and then 2016, in that period, we sent a team of investigators out into the field, and these investigators were typically human movement students who were used to anthropometric measurement, that is measuring height and weight, taking blood pressure, taking resting pulse rate and things like that. So we trained up a team of, I think it was about 10 field workers, human movement students, and they went and collected data from approximately 700 Habitat participants who agreed to be in this sub-study and put them through a large battery of tests that measured things like people's height and weight using scales and a stadiometer. Rather than people reporting their height and weight, which they also did, we measured their height and weight so we could compare the accuracy of self-reports versus measured height and weight. We also then put them through a series of tests, some of which were quite strenuous, to measure their physical functioning. And by that I mean someone's capacity to do things like bend, stretch, twist, reach. And so there are some standard tests that are internationally validated that measure the extent to which people's physical function is good as they age, because what we are trying to achieve, all of us as individuals as we age, is to remain in our homes, remain in our neighbourhoods, and to do that we need to be physically functioning well. We need to be able to get up in the morning. We need to be able to bathe ourselves. We need to be able to go shopping for food. We need to be able to reach out things from the cupboard. We need to twist and put a seatbelt on in the car. We need to get out of a seat. All of these aspects of physical function are important, particularly as we age. At the moment, when we're younger, we take these things for granted. But as we get older, our physical function declines, and we wanted to try and measure people's physical function and then relate it to the characteristics of their neighbourhoods where they lived, and therefore ask the question, did your neighbourhood environment influence your physical function? And did that change over time? Because the clinical sub-study was also a 2-time-point study. We would have liked to have collected more waves, but we've collected 2 waves of the clinical sub-study. They're quite resource-intensive studies because you've got to send people out into the field, into people's homes, and spend at least an hour with them, putting them through these quite strenuous tests. But it provides a lot of very rich and objective data. That is, it's measured data. And that sort of data has a high degree of acceptability among researchers and scientists, more so than self-reported data, because the amount of error is less and the amount of accuracy is higher in measured data. And so one of the key questions we wanted to address is, does where you live influence how well you function as you age? And how did this also differ by, say, for example, your socioeconomic characteristics? If you come from poor neighbourhoods, for example, how did your physical function differ from people who were living in rich neighbourhoods? And one of the themes that has run through Habitat ever since we started was the theme of inequality. We know that some neighbourhoods are poorer than others, and there are consequences of that in terms of the inbuilt environments of neighbourhoods. So some neighbourhoods have more green space, some neighbourhoods have more residential density, some neighbourhoods have more traffic, more pollution. And of course, when you've got more traffic, more pollution, they're detrimental to health in a number of ways. Air pollution influences, obviously, lung conditions, and more traffic on the road increases the likelihood of accidents. So there's a whole range of ways in which neighbourhood environments differ that might influence health and well-being, and socioeconomic factors are one of the things that are associated with how neighbourhoods differ. And we've published quite a number of papers from Habitat now that have looked at the neighbourhood characteristics of advantaged and disadvantaged neighbourhoods and linked it to health and well-being.
I guess one of the goals there with function and ageing is we want people to live long and healthy lives, but then die very quickly. What we don't want is for people to, in their final years, live with disease and have a long drawn-out death that, even from a financial perspective for society, can be quite expensive.
So one of the challenges, and you're correct, is to, I guess, find a way of bringing about morbidity compression. And by that I mean that, as you just alluded to, have people live as long a life and as healthy a life as possible without relying or having to engage with the healthcare system or the pharmaceutical benefits scheme for as long as possible. And to live life disease-free and functioning well, and have we're all going to die, of course, but I guess the ideal for all of us is to live a long and full and healthy and happy life, and to maybe have a short period of disease before death, rather than, say, for example, get diabetes in your 50s or experience heart disease in your 50s, and therefore have conditions that you need to then manage through pharmaceutical intervention for the next 20 years of your life. That's not only expensive and very inconvenient for the individual, but of course it's very expensive for society. The more people that get sicker early, the greater demands on the healthcare system and the pharmaceutical benefits scheme. And what we're trying to do is keep people out of hospitals, keep people in their homes, keep people functioning well for as long as possible, free of disease, free of functional impairment, and being able to enjoy life in their neighbourhoods. And if possible, avoid maybe going to nursing homes or things like that. So one of the challenges with the data that were collected with Habitat was to find ways of doing that. How could we keep people healthy, happy, living where they want to as they age, living in their homes typically, in their neighbourhoods, and not being essentially a burden on the healthcare system for themselves and society as a whole.
I want to ask you now about some of the main outcomes or outputs from the Habitat study. And I also want to ask you about your favourite. Now, I know this might be a bit like choosing a favourite child. So what were the main outcomes, the main outputs from Habitat, and then also what was your favourite output, do you think?
Habitat has looked at many issues since we first started the study in 2007. One of the key areas that we've looked at has been the issue of inequality. And so we've published many studies now that have shown that disadvantaged neighbourhoods in Brisbane have quite different health profiles than socioeconomically advantaged neighbourhoods in Brisbane. And that's in part due to the environmental characteristics of those neighbourhoods, as well as the characteristics of the individuals who live in their neighbourhoods. Because I'll just emphasise again, the Habitat study is primarily wanting to understand how your neighbourhood environment influences your health and well-being over and above the characteristics of you as a person. And so we found that disadvantaged neighbourhoods, they typically have higher rates of cardiovascular disease, of diabetes. They tend to people in poorer neighbourhoods tend to walk less for recreation, but interestingly, they walk more for transport. And so inequality has been a big theme through the study. We've also looked at physical function, again by inequality, and yes, what we found are people from disadvantaged backgrounds and neighbourhoods have poorer physical function. And so that means they're going to go into older age, not doing so well in terms of being able to stay out of hospital or relying on healthcare. And so physical function has been a big issue. We've looked at physical activity. Physical activity is one of the mainstay focus of the Habitat project. It was originally set up to understand how the physical activity characteristics of the neighbourhood environment could influence your health and well-being. And we found, typically that areas in Brisbane have very different physical activity profiles, be that physical activity for transport or physical activity for recreation. So physical activity has been another big theme, in addition to function, in addition to inequality. We've looked at body weight in terms of body mass index and the built environment and the neighbourhood environment factors that influence people's BMI. And we need to remember that all of these things are interrelated. So your neighbourhood environment might influence how you get out and whether or not you get out and walk or exercise. And it might be that the crime in your neighbourhood influences whether or not you go out and walk in your neighbourhood. And we know that physical activity is strongly related to diabetes. People who do less physical activity are more likely to have higher rates of diabetes. And so there's links between the environment, behaviour, physical activity, and outcomes like diabetes. So we've looked at these sorts of relationships within the study. We've looked at some interesting longitudinal relationships as well. And probably my favourite was a study where we looked at the relationship between transport use and body mass index. And we hypothesised that we know from previous studies that regular users of, say, a bicycle, or people who walk for transport, or even people that use public transport regularly, they tend to have body weights which are lower than those people who are car dependent. So we wanted to know whether or not, if you changed your transport mode over time, was that associated with a change in your body weight or your body mass index? And we were able to show that over a 4-wave period, that people who drove their cars regularly and used cars as the predominant form of transport, they typically had the highest body weight. Those people who transitioned, that is, they changed their mode during the study from, say, car to cycling or car to walking, their body weight lowered over time. And people who transitioned from, say, walking to a car, that is, they changed their mode and they put on weight. So it was quite a nice sort of demonstration of how transport mode can influence body weight, which then can influence a whole range of chronic diseases. But with the power of a longitudinal study was that we could examine change in transport mode and change in BMI. Now, what we didn't investigate, and I think it's a key question, is what are the factors that motivated change in transport? And things that influence change in transport are many. They could be environmental, or they could be individual. So we know from previous research, for example, that people who live in certain neighbourhoods, like highly dense neighbourhoods, say like Fitzroy, for example, there's a lower car ownership rate in certain neighbourhoods like Fitzroy compared with other neighbourhoods that are further out. And we know that people in places that are highly dense, they walk more, they cycle more, because these neighbourhoods are more dense, facilities and services are more convenient, they typically have better transport networks, and in general, people are lighter as a result. And so this study was just a little glimpse of how your transport that you use influences your body weight. And this was after we adjusted for people's age, their gender, their education level, their income, and their occupation. So even taking those things into account, which are themselves related to body weight, we were able to show that the transport mode that you used and whether or not you changed that over time influenced your BMI. I think that was quite a novel study, and we were able to use some fairly strong what are called causal inference techniques because we had a longitudinal design, and we were able to model the data in such a way that it would seem plausible, at least, that the relationships that we found were arguably causal. That if you were able to change your transport mode from, say, car to cycling, which involves then a greater energy expenditure and therefore a lower body weight. It made sense theoretically, and we were able to demonstrate that empirically with the data. Again, the power of a longitudinal study.
Well, Gavin, it's been an absolute pleasure to listen to you talk about the Habitat study, and thank you very much for coming in.
Thanks, Jeremy. I appreciate the opportunity.